To get your seats, we'll try to get started. Um, if our presenters would come on up to the table. Make sure your green light's on, and if you would, introduce yourself and identify yourself for the record.
Eddie Sloan, Kentucky Board of EMS, Executive Director.
Wayne Briscoe, Kentucky Board of EMS, Deputy Executive Director.
John Holder, the current chair of the Kentucky Board of EMS.
All right, guys, thanks for being here. If y'all would, please raise your right hand. Do you solemnly swear to tell the truth, the whole truth, nothing but the truth, so help you God?
I do.
All right, thank you, guys, and the floor is yours.
First, I think I'd like to thank you for taking the time to hear us out today in this subcommittee, and we'll get started, and we'll kind of jump in and out based on the presentation.
Okay.
But just kind of first want to kind of go over who we are. Kentucky Board of EMS, we only have 13 full-time staff. As you may or may not remember, we transitioned back to state government in 2022, and during that transition, we lost 6 employees as we came over. So we're running 6 employees leaner than we ever have. We have 9 office staff. We have 3 regional inspectors and 1 investigator across the Commonwealth. And we're charged with licensing, regulating the EMS system in the state of Kentucky. We license all the personnel, we license all the agencies, and we license all the EMS education institutes in Kentucky. What we're really here to talk about today is the additional budget request. I think as we looked at the original budget, operations stayed flat. We're not asking for any additional operations funding for office use. All this additional budget request beyond the 2 state mandated is for grant money back to the end user, which is our providers. We had 2 requests in this year's budget totaling $12,910,000. It broke it down into 2 different requests. The first one is $10.8 million in the EMS block grant. The second is a $2.1 million workforce education grant that would have funded what was known as House Bill 484 from the 2024 regular session. We have since had some discussions in looking in the $2.1 million ABR we're going to withdraw. Since the Rural Health Transformation funding rolled out, it appears that we're going to have some education dollars in there to kind of launch some initiatives in that front. So we would not need the general fund for that. As I stated, we're not asking for additional funding in any increase of office operations. So when we look at the block grant, the original block grant started in 1980, and I think you got to look and understand the progression of EMS quickly to kind of understand it. And it's still a pretty young profession. It really only started getting steam about the late 60s, and in about the early 70s, the federal government launched what they wanted to see and really push state governments into launching their EMS system. And they authorized somewhere around $160 million in grants to launch these programs in the states. And then kind of transitioned us to the 80s, which is where we'll really start to hit the ground, because I think in 1980 is when you really saw that transition from the load them in the back of the hearse into a true EMS system that you see today, in which you started to see this treatment and care given in the back of units. So as we talked about, we're really looking at the block grant funding. It goes back to 1980 with Senate Bill 66 is when it was established. And then I think Governor Brown worked with agencies and kind of looking at, we were still having struggles early on in trying to fund these, as we saw the $160 million to launch them. However, I don't think many communities were able to fund that sustainably. So when we look back at what Senate Bill 66, we take some of the wording out of the statute that it came from, and it was to preserve EMS funding in communities facing the discontinuance of service due to lack of adequate funding. And that was in 1980. Fast forward 46 years, and we're still in the same shape. We're still having communities facing the discontinuance of service due to lack of adequate funding. And there's several reasons why. And so that's where the Senate block grant initially started. So from the best we can tell, looking at historic documents, it looked like it started out at $1.2 million, and it allowed for a $10,000 max per county grant. So what did that cover? So when we look at the 1980s versus where we are now, again, we're looking at a 46-year history, but the cost of an ambulance in the 1980s cost somewhere around the $20,000 to $40,000. Again, it really depended on what make and model you got. But again, the big thing is the focus is that's when we started that initial transition into the new era of EMS systems and actually taking the care to the end user, which is the citizen, versus current cost. And I think as we look at what the current cost is, there's a number of reasons, but as you looked at healthcare transitions across this time, the level of care and that was issued then is tenfold what it used to be. We are essentially taking that ER or that ICU and transporting it to the patient. So the level of care and the transition that we've seen in healthcare in pre-hospital EMS has been tenfold.
This is the one item that I would like to speak about a bit, and we'll just talk about the cardiac monitor. I think it's important to remember that when we speak of this block grant, it's for equipment purchases, it's for ambulance purchases, is not for salaries. When we go back and look at the cost of just a cardiac monitor that was used in EMS in 1980, it was about $6,000. By comparison, today it's about $60,000. And I think what's really important to think about in this grant, when we talk about the equipment, most of the equipment, for example, this cardiac monitor, there were probably not more than a handful of them being utilized in the state. Most agencies in the state were BLS at the time. They weren't providing advanced life support at the time. So not only has the price went up, and by my research, it suggests that the inflation that the current grant would have, for inflation, medical inflation, $10,000, it would take $78,000 today to make that same purchase when we look at the inflation. But then couple that with the fact that most of the equipment in an ALS ambulance wasn't even utilized. I would bet it was probably less than 5% of the services in the state at that time were ALS. I'll make one quick point, that when you look at the equipment, I think probably that cardiac monitor that you see before you, and I'm not selling for cardiac monitors, is probably the biggest thing to come along during my career of about 35 years. When I started, we didn't even have an AED in the back of the ambulance, and it wasn't all that long ago. Now you think about this $60,000 monitor. It makes a difference for your constituents. When I started, someone having a heart attack, they had to go to the ER. We had to determine if they could get the what they called at the time the clot busters. Hopefully they hadn't had any GI bleeds. They weren't on certain blood thinners. They hadn't had any recent falls, no cuts, and a number of other things. And then if they had that, maybe they couldn't even go on to have open heart surgery because we gave them the clot buster. Now, all across the state of Kentucky, especially rural Kentucky, which will benefit by this block grant the most, you go 30 minutes out into the county, you may be an hour from the nearest hospital. They do this 12-lead ECG. They transmit the 12-lead ECG to the hospital. The cardiologist, or perhaps the cath lab team, or everyone else can look at this. They take that information, determine the appropriate hospital, and if wherever that appropriate hospital, they make sure that staff is waiting when that cardiac patient arrives. And in many cases, go straight to the cath lab. It's not uncommon for the heart attack to be stopped within 90 minutes. And I think that's probably the single most worthy piece of equipment that's come along during my career, and it is now $60,000. But in rural Kentucky, it makes such a difference. And that's just one piece of equipment the block grant would support.
And another, and I picked these three out specifically because they're probably the most three common that you're seeing in today's marketplace and especially the current grant processes. And then you look at the cost of the stretcher alone. We went from a single person operational unit, lightweight, to a more dynamic stretcher. It's heavier, but it's also heavier because it's more pneumatic, battery operated, and it's really designed to reduce risk on patients or on the providers, because you want to make sure that they're keeping the providers healthy. And that's why you're starting to see these big transitions coming into there. But you see the 1980 ambulance costing somewhere around $1,000 to current cost today running anywhere from $20,000 to $40,000 per unit. And I bring those three up because at the end of the day, this is what sums it up, is that when you compare cost of EMS operations from 1980 to 2026, it is exponentially more costly in today's market due to a number of reasons. You're looking at extreme higher labor cost, hourly rates, pension rates. You're seeing equipment costs, as we've seen just through some of the bigger purchases we see, have skyrocketed through the level of technology and the advancement that you see in healthcare today. But it also tied into that is the stagnant reimbursement rates. What people were able to kind of offset in the 1980s is not able to happen now because reimbursement rates have not kept up with the inflation and the cost of EMS operations. When you see ambulance transportation costs somewhere around upwards to $1,800, and getting reimbursement rates into the single digit and low teens, many local governments and agencies are operating in the red. Which brings us to the big talking point, which is our ABR request for $10.8 million. And we know that it's a hefty ask, but it's been 26 years since it was last touched. So, 46. What that will do is we've currently got $1.2 million that we allot currently for the block grant, and we give that out to about $10,000 per county. This would take it up to $12 million in hopes to get it up to $100,000 per county. It is 100% pass through to grant recipients. There is no administrative pull out of it. It's 100% pass through to the end users, which would be to the agencies. Ultimately, what we're asking for is taking that block grant from a 26 cents per capita expense to a $2.60 per capita expense for EMS and local governments. And with that, we will answer questions.
I'll start, and I'll circle back.
All right, go ahead, Representative.
All right. Thank you, Mr. Chairman, and thank you all for being here today. Thank you for your testimony. How many I know this is equally divided amongst counties, 10,000 each county, but sometimes there's multiple EMS providers within counties. How many counties have multiple? What's the total number statewide of EMS providers?
The total number of agency providers, I think, is going to run somewhere around 160 Class 1 agencies that are providing 911 response across the 120 counties. So when you look at your metro areas, your Jefferson counties, Northern Kentucky, Louisville, Lexington, you're going to see multiples. But to give you a total number of each individual county that's got multiples, I can't tell you, but I can tell you how many grant awards we've given out over the last 3 years in those total amounts. I think in the 23-24, we hit 91 counties. In 24-25, we had 108 counties approved. And in last year's 25-26, we had the highest in which we had issued to 110 counties.
And I think to answer some of your question, where there are 2 or 3 agencies within the county doing 911, perhaps one does the east end of the county, one does the west. It goes to the county court, where the county judge signs off on this grant. It comes back to them. So what we find is typically there's an arrangement worked out so that either they split the grant, or one takes grant on the odd years, one takes it on the even years to make the grant more substantial. But it is split through the county judge's office.
Okay, and one other question, Mr. Chair. Thank you. And then, two, we're talking about Senate Bill 66 from 1980, KRS 311A.155. Have y'all ever looked at reforming that statute? And have you ever looked at it as, okay, where's our most need in the state? Like, if we're going to put resources out as a state, how do we know it's getting to the districts that are, in most need? Because I know this is just kind of spread across the board, and it gets a little bit for everybody. But I don't know if you all have ever had any internal conversations about, hey, let's reform this, let's restructure this, so that the dollars that we do have, we can more targetedly, address these situations. Or if the state were to put in, more resources into this, like what's a good distribution? How can we go about that?
We absolutely have that conversation. That's a wonderful point. We had considered making a request to make it more of a competitive type of a grant to target certain areas at a certain given time. What we found was, in order to do that, we didn't think we could make enough of an impact in those few areas, and there were so many county services that relied on that grant every year that to take away from some to give to another, even temporarily, was going to cause a little bit of a hardship. So that conversation's continuing. We've discussed that before. We just didn't think it was feasible right now.
I've got, you were just talking about the equipment, and of course, with this block grant, 100% of the money goes to the grant applicants and goes to buy equipment for these departments. And a lot of times it's much needed equipment. You touched on the monitor and how the difference of expenses has increased with the monitors, because the monitors do more than just cardiac monitoring nowadays. So you can see that. But one of the things you touched on the difference in the stretchers. I think it'd be good to point out the price that you pointed out on that slide was just for the stretcher. Could you talk about the loading system a little bit, and what the cost is if you had the automatic loading system? And the reason why I ask you to do that, there's a twofold benefit for this. Not only allowing some of the rural smaller departments to afford that piece of equipment, but one of the number one, and you all correct me if I'm wrong on this statistic, but isn't one of the number one workman's comp claims or employee injury claims in EMS, back injuries, and this device will help eliminate that, if not 90%, almost altogether, because of the way it operates. I would just like you to point that out to the committee and to the people at home watching.
Yes, sir, Representative. That's a perfect point. Fantastic point. I think the cost point on those load systems is somewhere around $40,000. And you're spot on. We've noticed, obviously, with the increase in obesity among the citizenry that we support, and things like that, that's really become a concern with back injuries. And not only that, even your single back injury, your acute back injury, that's a concern for sure. But also over the length of your career, we're noticing that if you do this repetitive type of lifting for so long, those load systems are phenomenal on keeping those injuries down. I can tell you, as an EMS service director myself, I run 5 different counties, and we don't have any of them because they're $40,000 on top of the cot, on top of the stretcher, on top of the monitor. And so at the end of the day, when you're trying to make ends meet, I would love to have power load systems. I think that would help my staff, and I think it would keep them safe. I just can't afford it right now.
Well, and I've worked both for urban fire departments, and I've also worked for rural departments, and I've seen the difference. But the one thing that I want to kind of emphasize or point out to the committee is the cost that the local governments would have with, because if that was a mandatory piece of equipment to where every department had that, workman's comp insurance across the state for the EMS field would just greatly decrease. And because and I point that out because even though it's a small grant that we're trying to, you're all hoping that we can have the ability to increase the money, the equipment that it's buying and purchasing, especially for our rural departments and our smaller departments, it can be game changers, because it's going to have a twofold. Like in this case, it's a multifold process. It's not only going to help protect your crews and prevent workplace injuries. It's going to, one, more effectively load and unload patients, especially the ones that might be obese. So it's safer for the patient. It's safer for the EMTs or the paramedics. And when you're looking at cost efficiency and cost, it's going to provide more than just that. Grant money would provide more to the local communities than just buying that piece of equipment. And when you brought that up, it made me think of that, and I just thought that was something that would be an excellent point to show. A lot of even though it's the grant's 90% cost base for equipment, actually I think it's 100%, isn't it? Because every bit of it goes to equipment. There's going to be more benefit to the local governments and the smaller departments than just getting that piece of equipment. And I thought that was just an excellent.
And I would like to add on that just a bit, and I'll try to stay conscious of your time. But when I started EMS, the stretcher was a little less than 40 pounds. Over a few years, the stretcher weight itself became 88 pounds. Now they're up to about 120, but it went to 88 pounds for one simple reason: obesity and the safety of the patient. So they had to go to 88 pounds to make sure that they were stable when they were in the upright position. So then you took the weight of the patient, added 88 pounds. I came from fire and EMS, so we done both of them, right? Our number one workers' comp call was lifting, primarily lifting stretchers, hurt backs. Then when I come to the board and I look at the numbers, I have a whole different look at numbers. And so I've created some charts. I'm not the best in Excel, but looked at some charts. We're struggling with a staffing shortage, right? And so part of dealing with making sure that we have enough people to work in this field, I can show you that we start out at 20 years old or so, and it goes up, and we get folks to about 42 years old, they leave the field. And part of the reason they leave the field is because their bodies are worn out, whether it be lifting stretchers or lifting patients between in a small area of the bathroom and the shower, between the commode and the shower, whatever the case may be. Those are odd lifting, so we don't need to complicate that anymore using, for example, just the stretchers. If we want to, this keeps people, so this, right, using the stretcher and equipment in general, keeps people in the field longer. Even good equipment keeps people in the field longer, even if it's not for their health. No one wants poor equipment. But if we've got to do everything we can to keep folks in this industry because, again, I'll challenge you to go any rural area, and the workforce in EMS is a really difficult area because they're competing with too many other employers.
I would agree. Is there anything? One last thing I wanted y'all to maybe reiterate, and it's mainly for Representative Boland's benefit since he was coming from another committee. Explain the one ask that you had that you're withdrawing. Could you touch on that a little bit, just for Representative Boland's benefit?
Yes, I can go back, but it's probably so we had two original ABR requests in addition to this two state mandated. We had the 10.8 million in the block grant, and then we had a 2.1 million in the workforce education grant that was passed in the 24 regular session. As we've came through and learned that the rural health transformation funds, kind of what they're going to be divvied, we've decided to pull back on that 2.1 million, as we'll be able to use some of that rural health transformation fund to enact some of our workforce education initiatives. Therefore, we just really wanted to focus on the one additional budget request of 10.8 because it's going to have the greatest impact at the local agencies and being able to keep some of these agencies open a little bit longer and try to get.
All right. Thank you. Do you guys have anything else you want to add?
I'd simply say that I think that there are agencies. I can point out agencies today that are on the cusp of closing because they can't reach the funding needs to keep the doors open. And I do think this would be meaningful.
All right. Well, thank you, gentlemen, so much for being here, and thank you for your testimony today.
Thank you.
Thank you, sir.
With that, and since I do have a quorum now with Representative Bowling here, can I get a motion to approve our minutes from last meeting? And I'll second it. All in favor? Any opposed? All right, motion carries, and we are adjourned. Thank you all.
We very much appreciate it.
Of course.
I really want you to call JD and tell him.